Hey everybody, this is Dr. Matthew Love. Hopefully you all can hear and see me. First of all, I want to thank the marketing team for putting this all together and making sure that the volume and the camera and everything are working. So I'm Dr. Love again. I'm with the Urology Group here in Cincinnati. Tonight we're going to talk a little bit more about men's wellness, mainly focusing on understanding and treating BPH, or as most people call it, enlarged prostate. We'll kind of go through, and if any questions pop up, there are some options to type those in the chat, and we'll kind of try and take most of those as they're coming in. If not, we have some time at the end. Feel free throughout, interrupt, ask questions. This is meant to be informative. So again, appreciate everybody spending their night and hanging out with us this evening. So just a little bit about myself. Again, I'm mainly with the kind of the northern area of the urology group up in main office is up in Fairfield. I do operate a lot down in Norwood, and we actually have a new clinic up in Ross. Usually they're 1/2 day a week. From here locally, just across the river in northern Kentucky. So went to medical school, University of Louisville, went to Notre Dame, which is good or bad, depending on who you're talking to, football season time. Did do residency at Georgetown, did a year of general surgery at Vanderbilt. So kind of bounced all over the place before tricking my wife and convincing her to come back to Cincinnati. So obviously with one of my specialties and areas of interest is enlargement of the prostate, medical, surgical, behavioral ways of treating that. So we'll be focusing on that tonight. I also do a lot of kidney stone surgery, prevention, medical management, robotic surgery, mainly with reconstruction of the kidney, as well as kidney cancers, vasectomies, and also overactive bladder, which sometimes can have a little bit of overlap with patients with enlarged prostates. So starting off, what is BPH? BPH is benign prostatic hyperplasia, essentially enlarged prostate. Very high percentage of men have it. This is generally a non-cancerous, highly treatable condition. We usually say about 50% of guys in their 50s, 60% of guys in their 60s, and so on. Close to 90% of guys in their 80s or and above do have some symptoms of BPH. Now, that can range from being extremely minor, just some, slightly weaker stream, ranging all the way up to I can't urinate at all because my prostate's so big and now I have a catheter in. So very wide range of this, but again, an extremely common condition, especially as men age. So how does BPH affect your bladder? So this right here is a little bit of a visual of kind of what the lower urinary tract looks like. So you have the bladder, obviously with urine sitting in there. The prostate gland, the urethra runs right through the middle of that. So in normal healthy glands, your bladder is able to squeeze. You're able to empty your bladder without much of an issue. As men age and as those prostates enlarge, that just becomes more and more challenging for your bladder. So again, over time, that bladder, which is a muscle, tends to have to work over time, and over years and years of that bladder muscle can become a little bit thickened, and that's when you start having more permanent changes to the bladder and more long-term issues, or more concerning issues where that bladder just wears down over time because that prostate's so big. And again, that's generally what we're trying to prevent, and what we're trying to really keep patients out of the emergency room, keep catheters out of patients by addressing these issues when they're at earlier stages. So common symptoms of BPH, it is a very wide range of symptoms, whether it's frequency, urinary urgency, difficulty getting started, intermittent stream, hesitancy, dribbling at the end, really having to push to urinate. And again, a lot of that is just due to the fact that your outflow is partially obstructed and that bladder's having to work overtime. Some patients will also develop leakage, whether it's constant dribbling, leakage associated with I got to go to the restroom and I just can't get there quickly enough because of that irritation and because of that prostate growing within the bladder. Complications of BPH, I know we briefly touched on some of those with the visual of the prostate and bladder previously, but when your bladder is not emptying completely because that prostate's enlarged, patients start to develop urinary tract infections. So, incomplete emptying, you have stagnant urine. Bacteria love the fact that urine's not getting flushed out completely. And as a result, you get bacteria that builds up there and all the fun that goes along with UTIs, with more burning, frequency, urgency, pain, hospitalizations, ER visits, things like that we really want to try and avoid. Bladder stones are another possible sequela of enlargement of the prostate. So same sort of concept. You have urinary stasis, so that urine that's not getting flushed out as well as it should. You get little crystals, little calcifications that over time just progress, grow bigger and bigger, and ultimately, require surgical removal because these things get so big and can really exacerbate all of those BPH symptoms. Another thing is kidney failure. Now, this is generally end of the line, or if you have, a really more complex situation with enlargement of the prostate. I like to think of the whole lower urinary tract like a system of pipes. Us urologists, we're essentially just glorified plumbers. There's a blockage somewhere. There's fluid. There's urine that's not draining. Because of that big prostate, the bladder starts getting more and more distended. All that pressure has to go somewhere. So in some patients, you develop urinary leakage, or what we call urinary incontinence, because that bladder can just no longer hold any of that urine. In other cases, that urine starts to back up into the kidneys. So you can have a condition called hydronephrosis, which is just a fancy way of saying that your kidneys are swollen, your ureters, which are the drainage tubes of the kidneys, get swollen, and you can actually have complete kidney failure. We have patients that will be end-stage renal disease and end up on dialysis actually as a result of enlargement of the prostate. So, not something that we're seeing, multiple times a day, but a lot more common than most people would think. The other thing that we had mentioned, again, when the prostate gets more and more enlarged and that bladder muscle over the years and becomes a little bit more worn down to the point where it can't empty and can't create enough pressure to get past that enlarged prostate, you start developing long-term bladder damage requiring, catheter drainage, which is a tube that usually comes out through the penis that keeps that bladder drained and protects the kidneys and prevents from other issues from forming or worsening. BPH generally is not associated with any sort of cancer risk. So, again, a lot of folks are always worried, I'm having these urinary symptoms. Is this a symptom of prostate cancer? Generally, in a vast majority of patients, prostate cancer, you're not going to have any symptoms. Now, generally, when we're working patients up for enlargement of the prostate and some of these bothersome issues, we will do some tests and some exams that will help us really rule out cancer as a possible cause, but just enlargement of the prostate in itself does not increase the risk of cancer. So how is BPH diagnosed? Well, a lot of this is clinical diagnosis, right? We see you in the office, you're of that age range where prostates, cause more and more problems. You tell us you have a family history of it. Generally, that's our first suspicion. There are a couple other things that we can do to really rule out other issues. As we had mentioned, prostate cancer being one of them. There is a blood test called a PSA blood test, which is an easy test we can do in the office or you can have with your primary care doctor. Generally, we're recommending guys between the ages of 55 and 70 have this done. In some high-risk groups like African-American men or men with a very strong family history, sometimes we'll shift things back a bit and have you start getting checked a bit earlier. But easy test we can do in the office, just a simple blood test. Rules out, any significant cancers. There's a prostate exam that we do. Everyone's favorite thing about coming into the urologist office, I'm sure. The prostate exam, we go through the rectum, feel the prostate, and we can kind of assess size of the prostate and any major abnormalities in terms of nodularity or firmness that sometimes can tip us off that this may not be something simple like enlargement of the prostate and may be more of a cancer issue. There's also typically when we get you in the office, 2 other tests that we'll do. Other than just assessing some of your symptoms. One's just a quick urine test to look for other easily preventable causes. It's a test that takes us less than a minute to interpret, lets us know if there's blood in the urine, sugar in the urine, infection in the urine, other things that may steer us a little bit away from a BPH diagnosis, but may also be related. And there's also a non-invasive test called a bladder scan. So after you empty your bladder, if your bladder and prostate are functioning normally, your bladder should be empty or pretty close to it. So this bladder scan is a non-invasive test. We put a little ultrasound probe below the belly button with some ultrasound jelly, some cold jelly below the belly button. And that allows us to make sure that that bladder is emptying and we're not seeing any long-term issues. There are a couple other tests that we can do other than the quick, easy stuff that we do in the office. So let's say we're a little bit more worried about the bladder's health or really what we need to do or how aggressive we need to be about some of these treatments. There are a couple other things that we can do quickly in the office. There's a test that we've been using a lot more called UroCuff. And it's a way of us kind of looking at the functionality of how your prostate and bladder are interacting with one another. So When we do this, we have patients come in for just a quick nurse visit. It takes probably less than 10 to 15 minutes. We tell you to come into the office with a comfortably full bladder, not so much where you feel like you're gonna, urinate in your car walking in, but not so much, or not so empty where you're not going to be able to generate, a normal stream or a normal flow. We have this fancy device over here that I swear it's not a torture device. It's just a tiny little funnel that goes on the tip of the penis. Patients urinate. The report is instantly generated. So there's a lot of fancy physics and science behind this to give us an idea of, how well is your bladder functioning? How poorly is your urinary stream? Are you at risk for more deterioration of the bladder? Are you a patient who would really benefit from additional treatment of the prostate? So again, we're kind of steering more towards this in our group. It's a less invasive way of getting more functional information. There is another test called urodynamics. So it is probably a more definitive answer of the functionality of the lower urinary tract, but it is a little bit more invasive. It's a more time-intensive test. Our surgery center down in Norwood, they have specialized urodynamics machines, special urodynamics nurses who run, and a couple docs in our group who do all the interpretations for these. So a very small catheter goes into the bladder, but again, in more complex patients with maybe other neurologic issues, or patients we're really worried about more permanent bladder damage, this is a really nice test to give us more functional information. I do see that there's a question. I'm getting ready to hit right on that point, so it's a perfect segue for our next segment. The last couple things that we like to do in terms of BPH or what we call more advanced testing. So instead of just a quick urine test and a non-invasive ultrasound, what else can we do? Well, if you're one of those guys that we've maybe tried some medications, or you're not really interested in that, or you have one of these other abnormalities, whether it's of blood in the urine, or your PSAs may be a little elevated, there are some other things that we can do. One is a procedure called a cystoscopy. All that is just a fancy way of saying we take a really small camera, we put it in through the tip of the penis, look at the urethra, look at the prostate, look at the bladder. This really allows us to do two major things. Number one, we give you a lot of peace of mind by saying all these symptoms that you've been having that are really driving you crazy and impacting your quality of life are not due to a big bladder tumor. They're not due to a big bladder stone. There's no evidence of any other problem like scar tissue of the urethra, or what we call urethral stricture disease. And then we can say with a lot more confidence, yes, this is all due to enlargement of the prostate. We again, number one, rule out the bad stuff. Number two, this allows us to get a little bit better idea of some of your prostate anatomy. That way, if we're saying, the medications that we thought were cutting it are not quite doing what we want to improve your quality of life, what could we offer you surgically? So again, going along with that cystoscopy, what I usually will do at the same time while we have it under a little bit of light sedation is what we call transrectal ultrasound exam of the prostate. So just like the digital rectal exam, the quick prostate exam with the finger, this is a way more scientific way of just getting exact measurements of the prostate. So with the cystoscopy, with the ultrasound, this is something where we can say, number one, we're not seeing cancers. Your PSA looks fine. We're not seeing bladder cancers. This is most likely related to the prostate. And here are 1 or 2 or 4 different surgical options that you may be a candidate for. So it's a nice test to just give us a little bit more information, a little bit more advanced decision-making moving down the road. And then occasionally, again, if we have patients with abnormal exams or abnormal PSA, prostate-specific antigen testing, at that same time that we're doing the scope, we can actually get a biopsy of the prostate to get a little bit more information. So with this condition, multiple treatment options. The first question we had here is medication the only way to shrink the prostate? A lot of behavioral modifications and different things that you eat or drink are not necessarily going to shrink down the size of the prostate, but there are some medications that can do it. Surgery tends to be one of the other options. So again, being physicians that are conservative and being patients that are conservative, most people are not saying, hey, I just had this problem for the last 3 months, let's jump right into a big, operation. So we kind of have this spectrum of where we like to start patients and how we like to progress moving forward. So the first thing we'll talk about a little bit is, lifestyle behavioral modifications, right? Watching what you're eating, watching what you're drinking. Some patients will find that certain foods, certain drinks can irritate their bladder. I usually tell patients to make a diary. It sounds silly, but make a bladder diary. Write down everything you're eating, everything you're drinking for 5 days, for a week. You may find certain things in your diet that really make things way worse, whether it's alcohol or caffeine or soda or spicy foods. I've had patients that have just cut out artificial sweeteners. I had a patient the other day that didn't really make sense, but they said they cut out potatoes and other starches and their symptoms got way better. So again, we could avoid surgeries, we can avoid medications. So again, that first thing is doing what you can to avoid those triggers. Tobacco use, smoking tends to be a big risk factor that can irritate your bladder. Avoiding other medications, and we'll talk about this in a little bit more detail, but there are some, over-the-counter cold and flu and sinus medications, and we'll have some patients that will take those when they're sick. And if you have an enlarged prostate, sometimes that can make your bladder muscle a bit weaker and kind of tips the scales where all of a sudden you're having more and more trouble urinating. There are medications that we can give that, again, we'll touch on in just a bit. And then multiple procedures, which tend to be end of the line, but tend to be very, very helpful for patients. A couple other questions here. I'm taking a blood thinner, Xarelto, as well as another blood pressure medication, waking up every 2 hours, and usually voiding quite a bit. Again, with that can be a variation of normal. Some of that could be just due to prostate enlargement over time. Now, the Xarelto and usually a majority of blood pressure medications are not going to cause that. The prostate tends to be the most common reason for that, but there are other things like we had talked about, cutting back on fluid that you're drinking closer to dinner time. If the nighttime symptoms are the biggest issue, sometimes it's just cutting back on some of the fluids or, really intaking anything after dinner time. Sometimes there are other medical conditions like sleep apnea that can be undiagnosed that can actually cause predominant nighttime symptoms. So again, when we get you into the office, we kind of go into more detail about some of those other symptoms. Is this just nighttime? Is it daytime and nighttime? It's something that, again, we use the urinalysis, the post-void residual, some of the non-invasive stuff in the office first, then sometimes even trial out some medications. Lifestyle changes, again, we touched on this a little bit. So, cutting back on the fluids after dinner time, watching things that may be bladder triggers for you, caffeine, alcohol, soda, acidic foods. I don't want to tell you that you can't do any of these things, but, pay attention to some of those. You may find some triggers that are specific to you. We also encourage a couple other techniques that we call timed voiding or double voiding. So timed voiding, just getting on a schedule and saying, you know what, I'm going to go to the restroom every 2 hours, even if I don't feel like I need to. Sometimes by doing that, you can help retrain your bladder a bit, and that gives you a little bit more control just with some of those pelvic floor muscles. Sometimes the prostate enlargement just poses enough of a problem, and even when you're doing all these things, you're not getting where you want to be. That kind of moves us, to some of the other things like we had talked about, other medications, antihistamines, decongestants. Those things can slow down and kind of contract some areas in the pelvis, within the bladder neck, and within the prostate. So, when you are taking some of those, just be cognizant if you already have some baseline urinary symptoms, or talk with your urologist to just make sure that these are all okay to take. Or if you do develop worsening symptoms, stop those, talk with your urologist right away. There are a lot of over-the-counter medications that are kind of targeted towards a lot of the guys who are here at this talk tonight. I have bladder problems, I have prostate problems. There is not a whole lot of great data with all of these. So I do have a handful of patients who take these and say, you know what, when I came off of them, my symptoms got worse. When I'm on them, things seem to be better. I would say that's a very low percentage of patients, but none of those medications are necessarily harmful. But they also don't have any good, strong data, no randomized controlled trials to really prove that those work. Now, we have other medications that we do know work. So again, generally when patients are coming in, if they're asking me about that, I say it's not going to be harmful, but if you feel like it helps you and you're okay to pay the price for it, that's fine. A lot of the problem with these medications, honestly, too, is there's a high price point for it. And again, with no strong data, I generally steer my patients away from some of those. Usually the patients that we do like to use focus first on a class of medications called alpha blockers. So a lot of folks have heard of Flomax. Is kind of the name brand for a medication called tamsulosin. That tends to be one of the more common medications. And the way that whole class of medications works, it relaxes what we call the smooth muscle within the bladder neck and the prostate. So essentially, as that prostate grows inward, these medications will help slowly relax the muscle to allow that urinary stream to be a bit stronger. So again, with that medication, it tends to be cheap. These medications have been around for a while. They're very cost effective. The side effect profile tends to be pretty low with these. I usually tell guys to take them at nighttime before going to bed. It can very rarely cause a little dizziness or lightheadedness, and there are a couple other sexual side effects that it can hypothetically cause. The main thing that we warn patients about is if you're trying to have kids or you're in that age range where you're considering it, this will cause you to have no ejaculation or lower volume of ejaculation. Now, it doesn't affect erections. It doesn't decrease your libido or anything like that, but it will impact ejaculatory function. And as you'll see in the next couple of slides, we'll go through some surgical options that tend to have that as a side effect as well. There's another class of medications called 5-ARIs, or alpha reductase inhibitors. It's a class of medications that I think the first question had mentioned, is there medication or are there other options to shrink the prostate? So with these medications, over a longer period of time, it does shrink down the size of the prostate. So in patients who are really trying to avoid surgery, this is another medication that we will sometimes throw into the mix in conjunction with a medication like Flomax. I usually tell patients it's going to take you at least 2 to 3 months before you start to see any impact. It's not something that you take in the next week. Your urinary stream is like you were when you were 18 and you're knocking the porcelain off the toilet. It takes some time, but it can help with bleeding coming from the prostate. It can help with improving urinary flow, without having you do a surgery. The biggest issue with these medications is, number one, I had mentioned just the length of time it takes to get this medication really up and running. Number two, there can be some more sexual side effects, and less of the ejaculatory issues, more of libido issues, erectile dysfunction. There were some big studies that came out really within the last 10 years that really looked at more sexual function and found that there's a much higher percentage of patients than we thought that were developing some occasionally irreversible erectile issues. So I try and withhold this medication, especially for my younger patients with BPH, unless they're really trying to avoid surgery, unless they're having significant bleeding, or if they're an elderly patient that maybe isn't sexually active or really doesn't care about sexual activity, it's a nice option. Again, if we've tried the behavioral modifications, we've tried the medications, or the medications are causing side effects, normally my next step is saying, well, let's get you set for a cystoscopy and ultrasound. Let's take a look. Let's make sure there's not another problem. And let's see what surgical options you may be a candidate for. And so typically this is something that is 100% covered by insurance. We have a fantastic benefits department that does all the heavy lifting. That way you can be the patient and I can be the doctor, and we put all that work on them to go through that. But that's something that they work through to make sure that, these procedures are covered. And so kind of starting off with some of the less invasive procedures. The procedure that I like, and I do very frequently, is a procedure called Urolift. This is one of the more minimally invasive procedures to help with patients with enlarged prostate who maybe want to get off of medications, or maybe having side effects with medications, or just having progression of symptoms. So with the Urolift, it is a procedure that usually honestly takes about 15 to 20 minutes under a brief sedation. Most guys do pretty well with this. This is a very quick procedure. Patients go home the same day. And how it works is just like the cystoscopy procedure. We take a small camera, it goes through the urethra, the tube that you pee through, into the prostate, and we implant these small, almost like staples, that push that prostate out of the way. And the whole concept is to open that channel up to give you a nice wide open channel to urinate through, to empty your bladder more effectively. This is a fantastic option for patients who have kind of small to medium glands. Really, really large prostates, it's probably not the best for. If patients are really wanting to minimize sexual side effects, this is a good option. I would say about 95% of the time, patients do not have to have a catheter afterwards. So that's another advantage. Quick procedure, pretty quick turnaround, no cutting, so the bleeding risk is a lot less, and most of the time not having to have a catheter. So again, here's kind of a visual of how it works. We put a scope on the inside, we deploy. In most patients, it's around 4 implants. Sometimes it's less, sometimes it's more, and that really is just patient dependent on your specific anatomy. So the side effects, the risk of this, when we do this procedure, as if you're looking at step 3 there, we are preserving a couple different areas of the prostatic urethra that can allow you to keep your ejaculation. So we had talked about that condition called retrograde ejaculation that you can get with Flomax, right? It's when the ejaculation doesn't come out of the tip of the penis, it essentially just falls back into the bladder because that prostate is so relaxed. Generally, patients who want to preserve that, Urolift's a good option, and generally we're not seeing any erectile or ejaculatory issues. Patients will have some very minor blood in the urine, but again, we're not cutting, so that bleeding tends to be a lot less. I usually tell patients, I'm a little brutally honest when it comes to this. I tell patients, you're not going to like me for about a week or so. You're going to have a pretty bad flare up in frequency and urgency, burning. We send you home with a cocktail of medications that make it way more manageable. I had a patient that I just saw back yesterday or the day before and said, you warned me about all these terrible things. He said, it burned a lot for about 24 hours and I was back to my normal self with a much improved flow off of all medications within 48 hours. So I usually oversell that a little bit because some patients, it can be 1 to 2 weeks. Most of the time it's a little bit less than a week, but frequency, urgency, burning tends to be very, very common. With this test, because we're just pushing tissue out of the way, we're not taking out any tissue. There's nothing that's sent for pathology. But again, lower likelihood of needing a catheter. With the Urolift, it is a bit of a newer procedure. It's been around probably right around 10 years or so. So we're collecting more and more data. We know that it's something that's more durable than some of the other less invasive types of prostate surgeries that have come and gone over the years. So when you're talking about procedures coming and going, the TURP is definitely not one of those procedures. So the TURP is a transurethral resection of the prostate. This is really the gold standard for enlargement of the prostate. Urologists have been doing this since urology was a specialty. It's a procedure where, similar to that Urolift, we take a scope, we go on the inside, we look at the prostate, and we use electric cautery to kind of scoop out that prostate. A lot of patients have maybe had a friend or have heard of it called a Roto-Rooter. It's the same concept, right? We're just glorified plumbers. We go in there and we clean out the blockage. We shave everything down, open that prostate up, give you that nice wide open channel. Again, we consider this the gold standard. The reason that this procedure has stayed around is because we know it works. Very effective procedure, but it is a little bit more invasive than say a Urolift. So instead of a 15-minute procedure, usually closer to 45 minutes or an hour, just depending on the size of your prostate gland. A vast majority of these we still will do as outpatient procedures, so no need to stay in the hospital, overnight. The anesthesia is a little bit deeper and a little bit longer, but again, pretty negligible in the grand scheme of things. When we do this procedure, because we're shaving down and cutting the tissue, we do tend to leave a catheter. So that's that tube that comes out through the penis. The main reason for that is because patients will have a little bit more bleeding, and that catheter just acts to hold a little bit of pressure on the prostate fossa, that area that we shave down. Most of the time that stays in for about 24 to 48 hours. If we're doing it closer to the weekend, I'll oftentimes have patients take their own catheters out. If they don't like the idea of that and and they're fine keeping it for another day, sometimes we'll just get the patients back to the office after a day or two, make sure that urine is cleared up, and then get the catheter out. So with patients with the TURP, we tell everyone to expect to have some ejaculatory dysfunction, to expect to have that retrograde ejaculation. Again, my caveat is if you're not actively trying to have kids, it's generally not a big deal. But some guys, that's more important too, and just don't like the idea of not having that ejaculation coming out of the tip of the penis. Usually for that first week, I have you take it a little bit more easy than you would if you had a Urolift. Real heavy lifting, real physical activity, can stir up a little bit more bleeding in the prostate. So usually 1 to 2 weeks of some intermittent bleeding, a little bit of frequency, a little bit of urgency after that catheter comes out. And a lot of that's more related to the irritation from your catheter being in and less due to the TURP procedure. I find that patients that have a TURP generally have less irritative symptoms than a Urolift. The other advantage of this procedure, is that all the tissue we're taking out, we send off to be analyzed by a pathologist to just make sure that there's nothing cancerous. And again, in a vast majority of these patients, we're not seeing anything cancerous because that PSA, that digital rectal exam, has all been done ahead of time. So again, with a TURP, tends to be a gold standard, a little bit more invasive. And generally when we're doing that procedure, we'll tell patients it should last you about 8 to 10 years. Now, we do have some patients that 5, 6 years down the road, that prostate grows back. I have patients that have had TURPs 15 to 20 years ago and have been absolutely perfect since that time. So It's been around longer. We know it works. Probably a little bit more durable than the UroLift, but a little bit more invasive. A couple other options, different ways of using energy to treat the prostate. So I talked about the TURP being electrocautery to kind of scrape out. Similar to that, there's a procedure called a green light laser, or PVP, photovaporization of the laser, of the prostate, excuse me. Just a different way of using laser energy to, instead of cut that tissue out, to just vaporize it. Some patients who, for whatever reason, cannot get off blood thinners under any circumstances, this can be an option for you. Patients can stay on blood thinners during this. Most of these patients still are done on an outpatient basis, which means no overnight stay. Depending on the size of the gland, or if there's other health conditions, or with those blood thinners on, probably a slightly higher likelihood that we may keep you overnight in a hospital, but that's really up to your surgeon's discretion. And similar to the TURP, we do keep a catheter overnight for one night. I like the TURP a lot better than the green light, but there are a select group of patients that it makes sense for. Again, here's a graphic of sort of how it works. Similar to a TURP, a scope goes in, and just another way of using energy to vaporize and remove some of that tissue. So patients do tend to have ejaculatory dysfunction with the retrograde ejaculation. Very low risk of any sort of long-term erectile dysfunction with any of these. There are some patients that will experience some transient ED issues, but it is very, 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 very rare to have anything long-term. Patients with both the UroLift and the green light, I find, do have a little bit more burning and frequency and urgency for the first couple of weeks afterwards. And the other potential downside is we're not sending any of that tissue for pathologic analysis. So if we are worried about cancer, we're not sending any of that tissue with the green light. Another newer therapy that, again, has been around for a few years, but not nearly as long as something like a TURP, is a procedure called an aquablation. We do have one physician, maybe a second in our group, that are starting to do more of these aquablations. There's a procedure called Resume, which essentially just uses steam and a different energy with heat to eliminate that prostate tissue. And the advantage with this is some prostate glands that are larger are able to be treated a little bit more effectively with aquablation. The downside that we do see is it doesn't require a little bit more time than all the other surgeries that I mentioned, mainly with those glands being larger. Again, typically have to have a catheter for at least a night, sometimes a little bit longer. You do tend to see a few more bleeding complications with this. But again, if you're looking for a minimally invasive option that uses a little different type of energy, and one that can actually decrease, some of the ejaculatory dysfunction, this is another great option. So again, no impact on erectile or orgasmic function. That's kind of the big sell on both this and UroLift, is preserving that ejaculatory function, and a really low likelihood that you would have any issues with urinary leakage afterwards. So that's kind of for enlarged prostates that are not massively enlarged glands. So I actually had a question a little bit ago. I had a robotic surgery to reduce my prostate size, still having a weak stream, every couple of hours, having a little bit more frequently. So that kind of brings us into, it sounds like this gentleman had a much larger prostate that required a bigger procedure. So to answer his question, what are my next steps? I've had this surgery, I'm still having issues. Well, two things I would probably recommend if you haven't been back for a post-op check, or it's been a few years. One thing you can do is just an easy urine test in the office and a bladder scan, just to check and see and make sure there's no infection, make sure there's no blood in the urine. That would be another potential cause of this. If it's been a while since you've had that, it probably would make sense to even repeat a cystoscopy procedure, just to take a look and make sure that you haven't developed any scar tissue or any regrowth of any tissue in that area. Most of the time, restarting those medications is not going to be a huge win for you. So usually it would be starting off in the office with a bladder scan, a urine check, and maybe even repeating a scope to see if there's some regrowth of that tissue. So again, with these larger glands, two main surgical options that we have. One is called a HOLEP, a holmium laser enucleation of the prostate. The other is called a simple prostatectomy, which we'll touch on in just a second. So with a HOLEP, it is a really nice procedure that still allows us to treat these prostates endoscopically, which is through that cystoscope that we've talked about, without requiring incisions on the belly or a prolonged hospitalization or anything like that. So essentially, through that scope, we use laser energy to shell out the prostate. And I like to describe these big, massively enlarged prostate glands to patients who have them as essentially like an orange. You have the outside rind of the orange, which is the area where all your prostate nerves are at that allow you to have erections, that allow you to maintain your continence. And then you have the meat of the orange, which is that benign enlargement, that BPH portion of your prostate gland, which is the problematic area, which is the reason that you're having a weaker stream and really can't empty. So for guys with massive glands, we use that scope, we use the laser to kind of find that's what we call a surgical plane, right where the rind of the orange and the meat of the orange work. We enucleate that prostate, or sort of shell out that prostate, push it into the bladder, and we have some fancy devices that kind of chew that tissue up and remove it without us having to make a big open incision. The belly, most of the time, I believe the folks in our group that are doing this will actually send you home the same day. So again, the nice thing about a lot of these procedures is outpatient surgery. It does require general anesthesia. This is definitely going to be a longer procedure than something like a traditional TURP or a urolift. And again, that catheter is typically required to hold a little bit of pressure on that prostate area that we worked with. So similar to the other larger gland procedures, the retrograde ejaculation is very common. Expect to have some blood in the urine intermittently for a few weeks after the procedure, a little bit of some irritative symptoms, mainly from the catheter being in, and that prostate tissue is all sent off to be looked at by the pathologist. The last option, which again is another kind of a gold standard procedure for much larger glands, is something called a simple prostatectomy. So one of the gentlemen just asked a question, what do we do when, we have larger prostates? Usually we're talking about either a HoLEP or a robotic simple prostatectomy. It's the exact same concept of the HoLEP, except instead of doing it through a scope, we're making tiny little keyhole incisions within the abdominal wall, using a robot to help us very delicately dissect through the bladder, make a little incision in the bladder, and just shell out the prostate the same way. So again, great option for large prostates. With this, because we are doing a little bit more of an invasive approach, and we're making a little incision in the belly, we typically keep you around in the hospital overnight. We also tend to have that catheter for a little bit of a longer period of time, mainly to let that bladder heal up so we're not causing any sort of urine leak. So again, ejaculatory dysfunction, as with a lot of these other more invasive options, very, very common. Again, patients that have these really large glands, the simple prostatectomy, the HoLEP, while they are much more specialized procedures, tend to have really, really great outcomes, and patients are very, very happy. So I know a couple questions have been streaming in here as I've been rambling on. So let me quickly run through some of these, and then we'll open it up to more questions. So we have a gentleman who's in his early to mid 60s, who's had some issues with, it looks like, a little bit of an overactive bladder, frequency, urgency. And so kind of asking about, I'm not making as much urine at night. I'm urinating a lot more frequently. This is where I think these bladder diaries come in. It looks like this gentleman has been really tracking his output both at night and during the daytime. Some patients, have some crossover between overactive bladder and BPH. So again, one of the other things I talk about in my specialties, overactive bladder. A lot of patients with enlarged prostate, we tend to blame that first, and in a vast majority of patients, that's what's causing a lot of these overactive bladder symptoms. So the challenge in men who have potentially enlarged prostates and BPH glands are, if we're not addressing the prostate first and we're doing treatments that will slow down the bladder, sometimes we tip the scales too much, where instead of, being able to still empty your bladder and slowing down the stream, we've now slowed it down too much because we're more focused on the frequency and urgency. And because that prostate gland is still so big, that has slowed things down too much. We're needing a catheter. Now you're really straining to urinate, and these symptoms are drastically changing. So in patients where we're kind of on the fence, is this OAB, is this overactive bladder, or is this BPH? This is where I think these bladder diaries come in handy, dietary adjustments. Sometimes it's trial and error with overactive bladder medications or BPH medications. And then again, usually more of the advanced therapies will come in, where we say, let's do a cystoscopy. Let's look, let's take a peek. Let's make sure there's nothing else irritating inside the bladder. Let's make sure that this prostate gland is enlarged. I have some guys that have horrible nighttime symptoms, and horrible frequency and urgency. We look in the bladder, the prostate's not all that big, but they have a bladder tumor, or there's absolutely nothing going on. And we blame a lot of this on OAB, or overactive bladder. And that's when we're kind of focusing more on those types of treatments rather than surgical or medical treatments. So a couple other questions. What's the function of the prostate? Why is it just not removed? So I'll scroll back a few slides, see if I can find a prostate slide for you. So two main things that the prostate's used for. Number one, to urinate. So right through the center of the prostate is your urinary tract. So if we were to do a surgery to remove your prostate, like we do in patients with prostate cancer, we do what's called a radical prostatectomy. We completely remove that prostate gland. Well, when we do that, we have to reconnect the entire urinary tract. So the urethra, the tube you pee through, goes right through the middle of that. So it does help with urinary function. The ejaculatory duct, which is where all of your ejaculate comes from to allow you to have kids, it lives right within the prostate. The nerves that allow you to have erections live on the outside of the prostate. So it's very intertwined with urinary function, with sexual function. So I actually get that question a lot in clinic. What can I do? Why am I having these issues? Why can't you just take the whole thing out? Well, it's not a straightforward procedure. If we were to take the whole prostate out like we do with prostate cancer, that can be a 3 or more hour procedure. We then cause pretty severe and sometimes irreversible erectile dysfunction, and then you develop urinary leakage. So the prostate actually helps maintain continence, which is a fancy way of saying it allows you to hold your urine. And again, when it does grow and you have this benign enlargement, it can cause other symptoms. But it is a gland that's really intertwined with sexual and urinary function. Another great question: does increasing weight cause more pressure on the prostate and bladder? That is a great question. And yes, patients with that are overweight or patients with obesity tend to have more urinary symptoms. So it's always easier said than done when patients come in and say, well, what can I do? Well, the easy answer is, quit smoking. If you're a diabetic, control your diabetes, try and, eat well, avoid those bladder irritants, and try and lose a little bit of weight. Easier said than done, but that is something that's going to be great for your overall health, as well as for your overall urinary function. So with that, there have been some studies, mainly in the BPH and actually in the overactive bladder population, that simply losing weight, I say it as if it's an easy thing to do, simply losing weight can improve symptoms up to 80% in some patient populations. So again, we're urologists. We specialize in a lot of the surgical treatments, but again, the behavioral modifications, the conservative stuff is really our first line therapy. Losing weight, avoiding those bladder irritants, quitting smoking, doing those things that you can. Another question: I had prostate cancer over 10 years ago. I had radiation, symptoms getting worse, hourly irritation. So great question. That is a situation, again, where I think a cystoscopy would really make sense. Patients with radiation, especially with the history of prostate cancer, you can get scar tissue that forms within the urethra. So, even though we said your prostate's been radiated, maybe you're having prostate-related issues, sometimes just that collateral damage from the radiation, even if it was years and years ago, can cause scar tissue within the urethra, which can prevent you from emptying your bladder all the way, which will then result in you not having more frequency, having more urgency, because that bladder is just not emptying all the way. The other thing that can happen is you can have a condition called radiation cystitis, which is just a way of saying inflammation, irritation of the bladder, which again is caused by some of that collateral damage. Again, a cystoscopy, a scope into the bladder, is really the best way of evaluating that a little bit further. Some patients who have more minor irritative symptoms, we can start you off on some overactive bladder medications and just assume that this is more of a radiation cystitis or irritation picture. But if the symptoms aren't getting better, or again, we're tipping the scales too much, where now you're having weaker stream and trouble getting started, that's where I think a scope comes in handy. Some other questions. So a couple questions about kidney stones, a little bit out of the scope of this practice. What can you do? A lot of that is dietary. I do specialize in kidney stones as well, but big things we tell you there, increase your hydration. We want you to aim for about 2.5 liters of urine output a day to prevent stones. Low salt diet, low sugar diet, controlling dietary intake of high oxalate containing foods, high calcium containing foods. So sometimes even patients with kidney stones who have prostate issues, it can be a challenge because your urologist keeps telling you, we need you to drink more water, you got to stay more hydrated, and then you develop these other bothersome symptoms. So, with that, it can be a balancing act. So if you are a patient with kidney stones, you're hydrating like crazy, but your symptoms are driving you nuts, get in to see us. Again, we can do more of evaluation of your lower urinary tract. Another question is UroLift covered by Medicare? Absolutely. Again, as I had mentioned, there are people that are way smarter than me when it comes to all the insurance, but it is 100% guidelines based. The American Urologic Association recommends this for patients with enlarged prostates. Our benefits department is awesome. They make sure all those T's are crossed, I's are dotted. They get all the paperwork in to make sure that we've done the full workup. Generally, what the insurers will demand of us is the normal workup that we're going to be doing anyway, right? We're going to be doing a scope to look for other abnormal lesions within the bladder or abnormal prostate anatomy where you may or may not be a candidate for UroLift. They want an ultrasound or some sort of size, volumetric study of your prostate. They usually will want a PSA as well. So all those tests that we're doing as we're doing this workup, we'll check all those boxes for the insurance company. So they say, hey, you're 100% a candidate. Let's get this procedure done and let's get you feel better. So with the UroLift, if there's no improvement, can it be reversed? You just leave it in there. So you can remove the UroLift device, but normally that's involved. The involvement there is cutting it out. So when I have patients that are kind of on the fence of, do I want to do a TURP, the transurethral resection of the prostate, or do I want to do the UroLift? If patients are really focused on doing the less invasive thing, we can always try UroLift. I have had a handful of patients, that have had maybe some marginal improvement or said, I'm just not as good as I would want to be with this. And that's usually where we take the next step and either say, number one, we can just leave this. We don't need to do anything. Or if the symptoms are becoming more bothersome, we would then move on to a TURP where we actually go in there, shave out the tissue, and at the same time, we cut that UroLift out. So if you're not really getting much improvement, but you're not bothered enough to need a TURP or another procedure, we 100% would just leave it there. We end up just causing more problems if we're trying to find where those implants have embedded into the prostate and cut all those out. So Daryl asked another great question. What is retrograde ejaculation? A phrase that I probably threw out there 20 times and probably didn't explain it very well. So all that is a fancy way of saying you're not ejaculating through the tip of the penis. Retrograde just means backwards. So when we're giving you medication like Flomax or cutting out a major part of the prostate, the ejaculation, which begins in the ejaculatory duct within the prostate, instead of all those muscles in the prostate sort of contracting and pushing everything out through the tip of the penis, you will still actually ejaculate. It will just fall back into the bladder. So if you're looking at your urine with a microscope after you ejaculate, if you have retrograde ejaculation, you will see semen in your ejaculation or in your urine. Again, not a harmful thing, does not cause any medical problems, but if you're trying to have kids, we don't want to do this. So with the retrograde ejaculation, is it reversible? So with the procedures, no, it is not. When we're cutting that tissue out, this is a permanent thing. For patients who are on Flomax or one of those alpha blockers, when you come off of that medication, everything goes back to normal. So if you start on that medication, which is generally what we're doing, and you don't like it, you just stop it and everything kind of goes back to normal. And then it sometimes will help guide our treatment options moving forward. If that's a big deal for you and you don't like the way that it feels, maybe we look towards something like a Resume or something like a UroLift rather than the more traditional, but probably more definitive TURP. So with the UroLift, is it a permanent fix or does it have to be redone? Fantastic question. So as I had mentioned, it's a bit of a newer procedure. I want to say the company's been out and collecting data for maybe 8 or 9 years from now. It is, I would say anecdotally, it is going to be a less definitive procedure. The data is still out there, and I think they're probably in the process of collecting that 10-year data. NeoTract is the company who does that, and I think we just had our American Urologic Association, our big nationwide academic conference. I think they probably published some data there just within the last week. So something definitely that we can look into. But it is meant to be more long-term, but because it is a little less invasive and just the nature of the procedure, we do expect the prostate to continue to grow. With any of these surgeries, the prostate will slowly grow. So again, in a perfect world, when we're doing gold standard procedures, we expect maybe 10 good years out of that. With the UroLift, if we can get 10 good years, great. I've had patients who have had UroLifts 5-6 years ago who have been doing awesome. Sometimes there is the ability to redo it, to add in additional implants. If we do a scope and we look on the inside and we say, you know what, that urolift was perfectly positioned, but it's been 4 or 5 years and tissue's growing back, you have obstructive tissue that we can see. Great, we can do another urolift, put a couple other implants in there. Generally, if you're still really looking for that less invasive option, that's a good option. Most of the time, if it's, I had the urolift and I'm not totally satisfied with where I'm at, and and I'm less worried about some of the ejaculatory side effects, that's usually where I'll probably steer patients towards just doing a TURP to just do something a little bit more definitive. But every patient's different, and the anatomy is different in everyone. And sometimes we go in there and we say, well, this patient, we could put maybe 2 or 3 more implants in, but we have a really nice channel. And those patients say, I'm perfectly satisfied. But we kind of know that if their symptoms progress, 5, 6 years down the road, that they would probably be a candidate for, a couple other implants. Another question, what is ADH? How does it help? So there's medication which kind of focuses on tricking the kidneys into making less urine. So in some patients who have primary nocturia or nighttime urinary symptoms, really in the absence of any significant daytime symptoms, still usually we'll focus on those behavioral modifications, other medications like those alpha blockers, like Flomax, like alphazosin, Rapaflo. But what that medication does is it tricks some of the channels in your kidney into not diuresing, so not making as much urine and kind of holding on to some of that. So in some patients with conditions where they have very high volumes of urine at night, it tends to be isolated to nighttime. We've ruled out other conditions like sleep apnea, like restless leg syndrome, or other problems or behavioral things where you're just drinking a lot of fluid, or you have that water at the nightstand drinking all night. That is a medication that we can give. We do have to use it with caution. You can get some pretty significant electrolyte abnormalities with your sodium levels, so usually that's a medication that requires a little bit more lab work and a little bit closer follow-up initially, compared to some of the other medications which are really pretty darn safe and don't require lab value follow-up. How does alphazosin work? So alphazosin is one of those alpha blockers. So the way that it works is there are alpha receptors, which are specific receptors within the prostate and within the bladder neck. By blocking those, we allow that smooth muscle of the prostate and bladder to open up. So just like all those surgical procedures, what it does is it tricks those muscles into relaxing to open up to give you a nice wide open channel to urinate through. Another patient, I'm 71 years old. I'm getting up every couple hours throughout the night. My answer to that question is it depends. If you're not having blood in the urine, you're not having major nuisance symptoms, usually we would still want to get you in to just check a urine, make sure there's no infection, make sure there's not some other clear-cut cause. Now, if it's not drastically bothering you, you're able to get back to sleep, your quality of life is fine, we don't need to do anything. I have some patients that wake up once or twice a night and it drives them absolutely crazy. And they say, let's try medication, surgery, whatever we need to do. I have some patients that will wake up 4, 5, 6 times at night and they say, you know what, I don't really care. I get back to sleep. I'm retired. I can sleep a little bit more the next day. So a lot of that is patient dependent. If your symptoms drive you crazy, we can help out. If your symptoms are very manageable and your PSA levels are fine and your urine doesn't show any sort of blood, we don't need to do anything about it. Another question, my prostate is very large based on my MRI. I am on Flomax. Can we use other meds to reduce size? Yeah. So, if you were saying I really want to avoid surgery and my symptoms are definitely a nuisance, usually patients who have prostate glands bigger than about 40 grams, we would offer that finasteride medication, that 5-ARI class of medications. So great question. Again, you can see some sexual side effects. If that's not a problem for you and you really just want to avoid surgery, that would be a very reasonable option, although it can take a few months before that kicks in. If you've had an MRI, we're going to know the size of your prostate. And if you're saying it's 2 to 3 times the size of a normal gland, finasteride would probably be the best medical option to add into that for you moving forward. If you have cancer, prostate cancer, and you're taking Lupron or hormone shots, does this restrict most procedures? So actually it doesn't. One of the advantages of Lupron and some of those anti-androgen therapies that we give you for prostate cancer, it actually can shrink down the size of the prostate. So it's kind of like a souped up version of that finasteride. It can be used to slowly shrink down the size of the prostate. So sometimes when you're taking those hormones, you may actually see some urinary improvement. Now, if you haven't had radiation to the prostate and you're still having issues, still you're a candidate for us saying, let's do a scope, let's do an ultrasound, let's do that uroflow, let's kind of see what's going on with your lower urinary tract, and that, you may still be a candidate for us to go in there and kind of shave down the prostate and open things up a little bit more. And the unique thing with some patients with prostate cancer is, as that cancer grows, sometimes it will grow into the prostate, into the urethra, the tube that you pee out of, even more irregularly. So sometimes you may even benefit more from that TURP procedure to kind of go in there and shave out some of that potentially local advancement of some of that prostate cancer growth. What is my comment on the aquablation treatment for very enlarged prostate? So full disclosure, I do not do that procedure. I have a lot of folks that I talk with, a lot of urologists throughout the country that do it and really, really like it. I don't personally do it. It's a little bit more of a technical procedure. So we do have a doc in our group, Dr. Aaron Bay, who is doing the aquablation. I think is a reasonable option for patients who are more focused on preserving ejaculation, who may have those larger prostate glands. In my mind, and at least in my hands personally, and I'm biased because I like the TURP, I like the UroLift. I think they're very effective for prostate glands less than 80 grams. So I think if you have a larger gland and you don't want to have ejaculatory function, I think it is a really, really great option. And so again, we're even looking into some trials where we're stopping some blood flow to the prostate before doing something like an aquablation. There's a newer procedure that we're kind of looking into doing in our group, actually a little bit more, called prostate artery embolization, which is a way of actually having radiologists slow down the blood flow to the prostate, and that actually will help shrink down the prostate as well. So sometimes PAE, or prostate artery embolization therapy on its own, can be helpful, and there are some groups in the country that are actually doing aquablation with PAE, and there are some encouraging results. It is kind of like two procedures to accomplish the same thing, but I do think, again, with enlarged prostates, there are a lot of different surgical options. Another great question, how do you define small, medium, large prostates? A lot of it is just by the overall cubic centimeters or gram size. Some of it we can estimate with a finger exam, a digital rectal exam, but the transrectal ultrasound, that ultrasound probe, or even CT scans tend to give us a little bit better measurement. So prostate glands normally are around 20 to 40 grams. So kind of a normal size gland. When they get above 40, we would probably consider it a medium enlarged gland, where a medication like finasteride may be more appropriate if you were trying to avoid surgery. The UroLift, the TURP, the aquablation, all of those surgeries, usually we're talking about doing when that prostate gland's bigger than about 30 to 40 grams. There are still some patients with 25 gram prostates that may have more obstruction within the prostate, within that prostatic urethra. So just because your prostate's less than 30 grams doesn't mean that you can't have these procedures. We sometimes will just look into other medical options first, because that prostate isn't massively enlarged. Usually bigger than 80 grams tends to be our cutoff for much larger prostates. So that's when we start talking more about that HoLEP procedure, the aquablation, or even the robotic simple prostatectomy. Another question about alpha-zocin, there's alpha blocker medications. I usually recommend taking it at nighttime. The question was, it better to take it nighttime or morning? The medication stays in your system for about 24 hours. All patients take it differently. If you take it in the morning and it seems to work for you, great. You don't need to do anything differently. But I usually tell guys to take it at nighttime, because one of those side effects can be some lightheadedness, some dizziness. So if you're taking the medication, you're going to bed within an hour. If you're a little lightheaded but you're asleep, it doesn't really matter. If you're taking the medication then trying to go to work or drive a car and you're lightheaded, obviously much bigger problem. So I usually recommend taking those at nighttime. But I do have patients that have said, hey, I've been on alpha-zocin or Rapiflow or tamsulosin for years. I just take it every morning and I'm doing fine with it. That's when I take all my other pills. Not a big deal. Another great question that I should have answered, but I didn't. If you have surgery, do you still need to take the medications? 99% of the time, the answer to that is no. So that's another advantage of jumping to one of these surgeries. If you're not completely satisfied on the meds, I do have a pretty reasonable percentage of patients that will say, doc, my symptoms are there. I'm taking the Flomax, or I may be taking Flomax and finasteride. I'm happy with where my symptoms are at, but I hate taking these medications, whether it's the side effects or whether it's just 2 more pills. Maybe you're an otherwise healthy guy that, you really, those are the only medications you take and you just want to get off of them. That's where, again, I think these procedures are an awesome alternative to say, let's put you through a 15-minute, 20-minute Urolift after evaluating the bladder. Great, we've now pushed that prostate out of the way. Your urinary symptoms are just as good, or if not better, than they were with the medications. Now you're taking the medications off, 1, 2, 3 less pills that you're taking every single day. So great question. Now, some patients down the road, again, we talked about the fact that the prostate continues to grow. So 5, 6 years down the road, if you're having more symptoms, or even 2 years down the road, if you feel like, okay, my stream's getting a little weaker again, we can always get you back on that Flomax and see if that helps. But vast majority of the time, we stop those medications, and that tends to be a long-term, more durable option for you to come off of those medications. So all fantastic questions. I'll give you another minute or so to see if any other questions roll in. Let's see if there's anything else I missed here. Again, I know we went through a lot. It was just an hour session to kind of quickly run through workup, preventative measures, dietary, behavioral modifications, and all the different surgeries that we offer. I'm guessing most patients here are active patients of the Urology Group. If you're having more symptoms, if you haven't really talked to your doc about these issues, or you've gone in for kidney stones or ED or vasectomy or whatever it may be, other issues, and this is something that's been on your mind, just bring it up. All of us urologists are used to answering these questions. I was joking with our marketing team before this. This is easy for me. This is what I talk to probably 10 to 15 patients a day about every single day. So it is a very, very common condition. We have a lot of options, medical, surgical, non-surgical, all of the above. And all of our docs are very well equipped to, at the very least, get you started on the workup, whether it's, just doing the medications or kind of getting you to more of the advanced therapies. Looks like one other question rolled in. How much can meds reduce the size of the prostate? So it's marginal. When we give you that finasteride medication, we had mentioned, 6 months to a year of shrinking down the size of the prostate. You're not going to get more than a 50% reduction in the size of the prostate. If we're doing MRIs before and after taking finasteride for a year or so, it's going to be a smaller percentage. What's more important, though, is really how your symptoms are. Not all patients with big prostates have prostate symptoms, have BPH symptoms. So while it does shrink down the prostate, we're less worried about, how big or how small is your prostate now. We're more worried about what's your quality of life, what are your symptoms. And if we know that you have a big prostate and we've given you the finasteride and it's not doing much, that still, allows you to be a candidate for some of the surgical options. So another question talking about MRIs of the prostate. So, seems to provide a lot of information about both the bladder and the prostate. That is spot on. Veering a little off subject here in terms of BPH, MRIs of the prostate have really come into vogue over the last 10 years for patients who have concern for prostate cancer. In Europe right now, in a lot of patients before they're getting a prostate biopsy, where there's a concern for an elevated PSA or prostate cancer, almost all those patients are getting MRIs of the prostate, because MRIs have gotten better and better, and radiologists have gotten better and better at picking up on those high-grade, more concerning lesions of the prostate. So the American healthcare system and the insurance companies are not quite ready to say, yeah, this test is great and we're just going to pay for it for everyone. But to your point, MRIs are fantastic at looking at size of prostate glands. They are fantastic at looking and ruling out high-grade prostate cancer. So if you have an MRI of the prostate that is not showing any evidence of any concerning lesions or concerning cancers, usually we can tell you with about 80 to 90% certainty that there's nothing bad going on in your prostate. Now, it's not something that we routinely recommend for all of our BPH patients. In fact, the insurance won't cover it. And I would say you'd be hard pressed to find a urologist who's just going to do that test right off the bat. But if you are, having your PSA checked for other reasons, and your PSA has risen, or you've had a negative prostate biopsy and your PSA continues to climb, that is a perfect niche and a perfect role for that MRI to, number one, make sure there's nothing high grade that we would need to biopsy or potentially target with a biopsy. Number two, it gives us some more anatomical information about the prostate, about the bladder, to hopefully help guide treatment moving forward, whether again it's adding in that second BPH medication or giving you, presenting some options of different surgical values. So another question, if you have a urolift, does that stop the need to get up during the night? So tricky question. Our goal is to always improve all those urinary symptoms as much as possible. So we had mentioned some of the other causes of nighttime symptoms, whether it's fluid intake, obstructive sleep apnea that's undiagnosed. Excuse me, the hope would be if we're alleviating that blockage with something like a urolift, that you're emptying your bladder more effectively, more efficiently, that bladder is a lot emptier when you're going to bed, and it's taking a lot longer for that bladder to fill back up before you're getting that next urge. Is it a home run every single time? No. And I think the reason for that is probably because of, frankly, a lot of other medical conditions that can lead to any urinary symptoms. It's not always just the prostate, as we had mentioned. Patients with diabetes, as that sugar spills over into the urine, it makes you feel like you got to go a lot more. If you have undiagnosed sleep apnea, that actually is one of the biggest causes and undiagnosed reasons for patients who have primary nocturia or waking up at night to go. So the hope is, and I tell patients, we expect to see some improvement. Now, if you're waking up 6-7 times a night, do I expect that urolift to fix all the problems? No, but I would expect it to be heading in the right direction. I would expect improvement both in daytime and nighttime symptoms. Another good question, is PSA value impacted by large prostate glands? Absolutely. And that's where some of these other tests, like an MRI, can be helpful, or like an ultrasound of the prostate can be helpful to help assess the size of the gland a bit more. A lot of things can raise that PSA value, which is that prostate cancer screening value. The number one thing that we obviously worry about as urologists and as patients is prostate cancer. So, higher PSA, more concern for cancer. And that's usually when we're doing that biopsy before, jumping into surgery to, remove parts of the prostate or medications to focus on enlargement of the prostate. Big prostates make more PSA. As men age, prostates get bigger. And as men age, that PSA value will slowly go up over time. If you have an infection, if you have a urinary tract infection, if you had a catheter in for some reason, if you went and rode a bike for 20 miles and checked your PSA a couple hours later, or you ejaculated within a couple hours, or sometimes even within a day of having that PSA test, sometimes that can cause some fluctuations. So, if you've had a first-time PSA that seems a little abnormal, you can always ask your urologist, hey, can we just check another one just to confirm it's up? It's an easy blood test, like I said, that we can do in the office. But that is one test that we generally do like to check for any patients that are coming in for BPH-related issues. Is just checking that PSA to make sure, number one, we're ruling out prostate cancer. And then again, sometimes as we're doing this workup, we find that you just have a massively enlarged prostate, which would explain that PSA elevation over, something malignant. All right. Well, it looks like we're a little beyond the hour and 7 minutes. Hopefully I don't get in trouble from our marketing team here. But again, thank you guys for all coming out. I know it's, an hour plus out of your evening. Any questions, any concerns, you see our contact number here. Visit our website. We're getting more and more resources by the day. We're kind of all over the greater Cincinnati area and branching out in some of the outlying areas. Like I said, I have a clinic up in Ross, which is kind of the northwest side of the city. We have folks that are heading farther south in northern Kentucky and southern Indiana and Oxford and all the way out in the east side, the far east. So give us a call. Keep us in mind if you're having issues. Talk to your urologist about it. If you don't have a urologist or want to see someone, we have plenty of docs in our group who are more than happy to take care of these conditions. So again, really appreciate you guys spending our time with us and keep us in the loop in any way that we can help. Take care and have a great night.